I'm delighted to have the job of introducing our headline speaker, Steve Reed. Steve has been working in equine neurology for 42 years, he tells me. The first 31 of those was at the Ohio State University in a teaching and clinical role. And for the last 11 years, he's been at the Rood and Riddle practice in Lexington, Kentucky. Steve.
Thank you. Thank you, Celia, and thank all of you for coming to hear about something, one of the things that often gets said about neurology is it's a euphemism for necropsy, and so hopefully today we can share a little bit about making things a little different. This is where I work now. This is not anything that I or anyone would ever do in isolation. I have several colleagues, and Dr. Woody is a surgeon. I do internal medicine, so I'm an internist with an interest in neurology. There are now some large animal boarded neurologists, specialists. Jennifer Janes, I was on her PhD committee as a pathologist. I have been here before. And so can you recognize all the folks up there? Did I say that you'd be on there, Nick? I said. So, and Lawrence Gehring, myself, I was much thinner, had dark hair then. Dr. Greet, I think he looks like he was, about 12? And Roger Barklam, who was someone with a broker, I believe, who had invited us to come, and Shaq Parrish, who actually organized this. And we came and had a discussion with veterinarians and underwriters and brokers at that time. A little bit of history about wobblers. So this, when I went to Washington State University, I taught there as well as at Ohio State. That was about 1979. In this picture, we have Dr. Barry Grant. Well, actually, if I start on the far left, the gentleman with the hat is Dr. George Bagby, a human orthopedic surgeon who designed and modified the surgery for working on horses. Next to him is the anesthesiologist, Paul Clavino, Dr. Barry Grant, Molly, who was our tech, some veterinary students who I don't know, Art Ortenberg, Dr. Pam Wagner, who was the surgeon and did it as her master's project, and then Dr. Mary Rose Parody, an internist who was a resident at the time. Dr. Wagner is a bold lady as well, in that at age 50, she decided to stop being a veterinarian and went to medical school and became, so she was a veterinary surgeon and a human internist, and so quite interesting. Dr. Grant always said the Lord hates a coward, so the horse in that picture is a horse named Secret Intent, a son of Secretariat, who was a wobbler, and Dr. Grant galloping the horse with no helmet or anything after its wobbler surgery, and so in any event. So this is kind of a 30-year journey talking about wobblers and advances in diagnostics as well as other things. So I thought I'd cover a little background, some clinical assessment, but we have others in the room who will probably support and or advance things that I might say. Of all the speakers I know, some I've just met, some I've known a long time, and Dr. Piercy in particular up at the front was one of our residents at Ohio State, and Richard, he's always been an intrigue to me because not only is he very bright and industrious, but he took things that I said and worked to make them better, and so we'll hear about that later. So what about wobblers? Well, it's had a lot of names, of some, very common, but there was some early work back in the 30s by Dimmick and Arrington there at the Gluck Center. But what is really going on? So in this picture is a nice depiction of what it might look like when the vertebral column are out of alignment. And some of these things have been published a long time ago. One of the things that I somewhat use as a Bible is an article that's published in the Cornell Veterinarian around 1976, and it's Dr. Mayhew's PhD thesis. Joe Mayhew, who many of you probably know because he used to be here, back home in New Zealand now, talked about it. But the bottom line is we're looking at a narrow vertebral canal. This little cartoon movie gives us a little of an idea of what we're actually looking at in the vertebra, and it's it's the narrowing in that vertebral canal that's such a key thing, and it can occur either in a dynamic position or sometimes associated with stenosis, and we'll talk about how that happens here in just a minute. One thing that I would say, and I know that Celia's told me, and I promised to stay on time, but I'm absolutely fine to be interrupted. If someone has a question that you'd like to ask at any point in time, stop me and we can move forward. This was a slide that talks about what happens at the diagnostic lab. And so developmental problems that have been looked at the University of Kentucky, and I work very closely with the diagnostic lab at the University of Kentucky, all of the green ones, all of the developmental problems, 31% were wobblers over a period of time. So whilst we see problems in the appendicular skeleton that are developmental as well, they're not likely to lead to postmortem. So when it's in the vertebral column, again, it's a more problematic thing. So it can be a fairly important issue in the horse's lives. So it's a common cause of ataxia. It can be a developmental problem. It typically is seen in light breed horses. And it also, we see it as an acquired problem. I think probably all of them started with the same sort of pathogenesis, probably developmental OCD lesions in the articular process joints or changes in the growth plates in the vertebral column. We see it much more commonly in male over female. It used to be said 2 to 1. I'd say it's closer to 3 to 1, maybe sometimes 3.5 to 1 male over female. We see it in thoroughbreds, but we see other light breed horses that also have this particular problem. And we see it of the ones that we end up doing surgery on. I'm not a surgeon, but I scrub and assist on every one of those. And I guess I've been in on about 500 of them. So I suppose if Dr. Woody were to faint, I could finish it up, but hope that never happens. We see it from 6 months to 7 years, and the clinical presentations are usually typical, but not always. So what are the factors? Rapid growth, high energy diets, trace nutrient balance that may be important in enzymes like lysyl oxidase that are going to be helpful in conversion of cartilage into bone. So a developmental problem. Genetics play a role in it, and we'll talk about that towards the end of this. And then day-to-day trauma. We see this as an acute onset sometimes in horses that have just been playing hard one day. This is a group of horses that I looked at over a 10-year period at Rood and Riddle. So there were 252 of them, and that chart will come up again in a minute. But I want to put this together so that you can get a little bit of an idea about how this problem starts. So this is a problem that probably begins in utero. So there's vertebral development that's going to start right at conception, obviously, and there's going to be a rapid period of growth in utero. And then from birth, there'll be another rapid period of growth. And then finally, in the postnatal period, when they hit puberty, we'll see that again, another period of rapid growth. But the growth plates in the neck don't close until all the way out to 5 or 6 years of age. And so the genotype might get set right away at conception. So they may have some predilection as early as that. And then there are going to be these developmental osteochondrosis type things, this difficulty converting cartilage into bone that occur in that early phases in utero as well as in the early postnatal phases. But then there are environmental factors that are important in this. The role of diet, the role of trauma. So there are other things that might occur. And looking back at that's the same picture. Now you can see that the peaks occur, that first peak between 0.5 and 1 year of age, and then between 1 and 1.5 years of age is when we usually typically see the onset of this particular problem. So what about the clinical assessment? I think I'm going to be really brief here because I believe this is going to be discussed by the other speakers in the room, but obviously the neurologic exam is going to be one of the most critical things that we're doing. You've got to get an anatomic localization. Then you're going to take radiographs, and we'll talk a little bit about some of the work that we published on that, myelography. And this is an intriguing thing. It's still, for me, the most important antemortem test that we do to decide whether or not to go to surgery. And as was mentioned, I've been doing this 42 years. Even when I was a resident, so starting in 1976, I developed an interest in looking at this problem, and there's still some days I struggle to read the myelogram. And I see other nodding in here. If you're doing this, it just can be one of the problems. If we had the ability to do MRIs on all these horses, we would then be able to get a better assessment of that. And some of the measurements that we're going to talk about done on MRIs, sadly, these were done on post-mortem specimens, are been useful now in the CT measurements, which we can have CT units big enough to do horses. To develop an MRI large enough to do the entire vertebral column, cervical vertebral column of a horse, physics-wise, is just not going to happen, at least probably not in my career time. And then there are other things that might be helpful. So CT, MRI, myeloscopy, so there are people putting scopes down in there. I think I have one picture of that. But maybe some other tests that we could develop either on CSF. What do they look like? This is just a horse walking, and I think you can see they have no evidence of brainstem or cranial nerve abnormalities. They have gait deficits that involve all four limbs. And the chubby guy in the scrubs, that's me over here. The tech leading the horse, I always throw in a lot of anecdotes. Brent was a great technician. Unfortunately, when Rachel Alexander got a bad colic problem post-foaling, Brent was the tech who took care of her, and he took such good care of her that the farm hired him away. So he now works for Stone Street and looks after things. But we'll see more about the neuroexam here in a minute, but I do want to back up. So the neuroexam, I think getting a history and then making a neuroexam as a part of your physical exam is critical. It just, you know, even though our orthopedic surgeons, who we have excellent ones, are not interested in doing surgery on necks. They've got plenty of other stuff to do on the rest of the horse. I noticed that every time they do their lameness exams, there's out there doing little circles and a brief neuroexam on many of the horses. And so I think it should just be an extension of the physical examination. So what are the things that there are some things that I think are helpful. Sometimes the signs can be quite subtle, so you need to look really closely at what you're doing. And then there are a few little things that you might pick up, such as at the very bottom. Horses that are constantly pulling their front shoes, or the people will say to me, they just about got this heel bulb almost healed up, and then it tore it off again. They overreach and grab themselves up front. Those are subtle signs that maybe it's not a lameness, maybe it's a neurologic problem. So I try to look at those things. You may be able to benefit from some other diagnostic tests, and I think we're going to hear more about those throughout the day as well. And this is taken from Dr. Mayhew's thesis, reminding us of the neuroanatomic localization. So at the site of the lesion, there's going to be damage to both the ascending and the descending spinal cord tracts. So the picture in the middle, ahead of the lesion, will only be getting the ascending tracts. Below the lesion, the descending tracts. So you can get a good anatomic localization at postmortem. I threw this in because I thought it was interesting. I talk a lot, so when I'm doing the neuro exam, I'm out there jabbering along, and there was a vet student from Michigan State with me, and we were talking about various things, and I was trying to explain to her where the tracks were that were causing those clinical signs. So the next morning, she came in and said, Dr. Reed, I went back and I drew a picture of what you were talking about yesterday. I was quite impressed that she took the time to look it up, because there's no doubt that understanding the anatomy and physiology, always first principles, it'll get you the farthest down the road in dealing with any problem. So what about diagnostic imaging? Well, early on, Dr. Bonnie Rush, or Bonnie Rush Moore was at that time, did a project in which we were measuring inter and intra-vertebral sagittal ratios. And we'll talk about those things, what these little letters mean here. And it was actually quite helpful. What we did was we took one of our radiologists, Dr. Rush, who was the resident, and me, the person looking at the cases, and we took 200 sets of radiographs, and each of us read those films independently. So the radiologist, Dr. Biller, Dr. Rush read them, and I read them, and we made measurements to measure the width of the vertebral canal, and we made a comparison to the width of the vertebral body near the proximal growth plate, trying to be perpendicular to the canal. And what we found was that whenever the vertebral canal was less, 50% or less, than the width of the vertebral body for C3, 4, and 5, that if we went ahead and did a myelogram, 80% of the time it was too narrow. So it was a pretty, we thought, a very accurate thing. For C6, it's 52%. For C7, it's 56%. So you can make measurements, the width of the canal at the narrowest spot, and compare it to the width of the body. Now, this cartoon actually was done by Dr. Hahn in a paper that Caroline wrote. So a number of other people have, looked at these measurements. And this is just what it looks like when I look at a set of radiographs. I just put all these lines in there and do ratios on them, and I try to go both between vertebra as well as within vertebra. And we'll see why that's important in a minute. So the best antemortem test for us, until we get a good CT unit, we're putting one in at Rood and Riddle soon. We had one and it wasn't very good, so we sent it back and are getting another one. But for right now, the myelogram still remains what I have to use to make the decision about it. So here's a little bit of what it looks like at Rood and Riddle. I thought there was music, but we don't have that, so you have to bear with me. This is what our hospital and place looks like, so there. But in doing the myelogram, there's Dr. Gilsonen's one of the internists. I'm the chubby guy. Peter Morrissey is another internist. Emma is a young vet from Australia who's now off doing a medicine residency. So there is some labor, Dr. Morrissey there. The myelogram table, excuse me, is a big help. I felt bad about this video because we've now painted the board with our logo on it, so it looks much more attractive, but I didn't have time to redo the video. So we put the head in an elevated position, then I do the atlantal occipital CSF tap. We take the spinal fluid out. For us, it's also really important to rule out protozoal myelitis. That would be the second most common cause of neurologic disease that we see. Then, we put about we remove about 30 cc's of spinal fluid, put in about 50 mLs of iohexol. And then it's nice to be able to take the radiographs on that table because the plexiglass moves back and forth. So you don't have to be doing a lot of hard labor to get the horse to get those films. But again, that's just a quick depiction of doing it. But this is what we're going to be looking at. So here we've got C1 to the left and going down the C2, 3, 4, 5, and you can see normally you're going to have some degree of attenuation of the ventral contrast column when you flex the neck. But if you have a loss of the ventral with a greater than 50% narrowing of the dorsal, again, those are just measurements that are out there and they're getting debated all the time. When they're as dramatic as this, as you see at this one at C6, 7, where it looks like an hourglass, I think that's much easier to make that assessment. And this is often associated with an arthropathy. So we see this, used to be said that that was the most common in horses over 5. This is the most common lesion we see in our hospital in yearlings and 2-year-olds right now. So I don't know what's changed, but that's very typical. We even have some spotted horses we're doing myelograms on. But at any rate, so this is just a quick picture of it. And I think that probably one of the things that is important, if you look at this, and I apologize for not having a pointer, and I hope everyone can bear with me, but there are, again, just like I said, difficulty with reading the myelogram, there are all kinds of rules. So there's one rule that says if the dorsal contrast column is less than 2 millimeters, that's a positive myelogram. There's another one that says if the total dural sagittal diameter for horses less than 320 kilograms is under 1.2, you know, there are all these measurements that people have done. There's another where we look at the mid-body and we measure if this is a greater than 50% reduction of just that dorsal contrast column. So there are lots and lots of things. I don't know, are you going to address this? Somebody, I think, is going to talk more about interpreting myelograms. But when you look at it on the MRI, I think the key thing is that you can see, here's the articular processes, here's where the spinal cord's going to live. We might have an OCD fragment like you have right here, but all of those things that can lead to narrowing of the vertebral canal are responsible for what's causing the clinical signs in this horse. And so here's an MRI image showing things. These are the articular process joints. Here's the spinal cord in the middle, the CSF surrounding the cord in there, the vertebral body. And again, this is the musculature around that. But here just showing some images. There's no compression, so you can see everything looking very fine. And here's one that has quite significant compression with shape change in the spinal cord, edema in the spinal cord, loss of the spinal fluid. And yet this one, when you look at these articular process joints, they don't look all that abnormal, maybe a little bit of a change right here, but they certainly are enlarged. And then other times you see dramatic changes in those articular process joints. Those problems start very, very early in life and can lead to the narrowing of the canal. And look, sometimes the articular processes can actually look like they've had a fracture where there's just a separate fragment, again, a developmental problem in there. And other times it'll be more obvious on one side than on the other, and it'll be more obvious in one articular process compared to the other. So remember, this one's going to be from the cranial vertebra, from the caudal vertebra. So looking at that. And again, this is how bad the spinal cord can look on some of these MRI images, and you can just see the dramatic changes. So our enlargement of the articular process joint, the left over the right, and then the significant narrowing and compression of that cord. So again, Dr. Janes, as a part of her PhD project, took a look at comparing magnetic resonance imaging with the standing cervical radiographs. And this, I thought, was quite helpful. So we were measuring the area of the spinal cord within the canal. So you let me know if I'm going too fast or too slow. Yell at me, because I tend to talk fast. But again, these measurements can be quite helpful, and we were able to calculate the surface. Even though it's difficult to do the entire neck on an MRI in a living horse, these measurements have proved quite worthwhile, because now individuals who are able to do CT contrast or CT even without contrast are making similar measurements. So this publication has been quite helpful. This is just a depiction of the blue dots are no evidence of compression, and the red ones are histologic evidence of it. And this is just an example that when you did it just using those radiographic measurements, you can see that we had some horses that didn't segregate quite right. So we called some that were not so narrow, too narrow, and vice versa. But when we used that canal area ratio, it separated the cases out quite well. So I think being able to make those kind of measurements has been a really, really helpful thing. And you can see the two that were in the wrong spot when we did the canal area ratio measurements. They moved over to the proper place in there. Again, radiographic comparison of the minimal sagittal diameters on radiograph to the spinal cord, measuring the canal area ratio of cord, again, was another similar outcome that the radiographs, the myelograms, all of those things can be difficult to interpret, but until we get the ability to do better imaging. And we may hear about that hopefully in another talk. And then what about other things? Well, there is this paper by Timo Prang, a surgeon at North Carolina, who looked at putting a little scope inside there. So what does that look like? Well, he slid right into the area around the spinal cord, and you can look at all these blood vessels. I'm sure when you're sliding that scope down there, it's probably not too good for those vessels because you're going to be dissecting them away. But again, it does give you the ability to take a look at that in a different way. This has not caught on as a big procedure. So he did 6 healthy horses looking at them. So the vertebral lesions of pathogenesis, we've already addressed, a lot of this is what a normal looks like, but what are those epigenetic, the other factors that are really, really important in this? Well, there are some genetic variables, and early on, one of the things that when I was putting this talk together that I sort of thought about is that sometimes these are strongly held, but I want to say erroneous opinions. And the idea that it's totally genetics is just not right. Is there a genetic predisposition? No doubt about it. But it's not totally an inherited problem. And so environmental factors can also be critical. And what are some of those environmental factors? Well, some of them are diet, rate of growth, gender. As I said, we see it 3-to-1 male over female. So the two models in the pathogenesis for this particular problem, one starts out with that it's totally associated with abnormal biomechanical stresses leading to the problem. And the other is that it's a result of abnormal bone development and growth. I think the reality is they're both important. No doubt that abnormal bone development is going to be a big part of the initiation of this, leading to some of these abnormal biomechanical stresses on there. So you've got to know the normal anatomy, and then what are the abnormal forces that might be critical in this, leading to this stenosis, or are these arthritic changes? So in other words, if you had a poor OCD or some poor development of an articular process that then later turned into DJD. And sometimes when we radiograph these necks, those articular processes will look the size of a softball or maybe even larger. They can be quite dramatic changes that occur over time. So here are the pathologies that we see. OCD right at the top, true bone cysts, synovial cysts, and I'll show you some pictures of these, all sorts of changes. And these things like this epiphyseal flaring, this, we see the same thing in the long bones, in those horses that have epiphysitis and physitis of the appendicular skeleton. So distal radial physitis or epiphysitis, same things happening in the vertebral column, leading to narrowing. But again, then the soft tissues that are in there can also hypertrophy and be important parts of it. So what kind of things am I talking about? Well, the dorsal lamina, so now here you're looking at vertebrae. If the dorsal lamina starts to elongate, that's going to be really important, because you remember on that little cartoon where we see the vertebra moving up and down, well, if the spinal cord gets pushed up, but it goes into a space where there's no bone, so what? It's not a big deal. If it pushes up against a dorsal lamina, it's going to then cause compression. The caudal epiphyseal flaring, so we can get this epiphysitis or physitis here that, again, can lead to narrowing of that particular vertebral canal. So this just, describing what I just said. Sometimes we have actual subluxation and malalignment. between cervical vertebra, leading to, again, what can be compression of the spinal cord. And then those articular process joints are true joints. They have articular cartilage, they have a joint capsule, they have joint fluid. Sometimes they get outpouchings of those joint capsules due to synovitis or other things, leading now to a soft tissue compression of the spinal cord. So these horses might be ones that if you were to use an ultrasound-guided injection into that articular process joint, you might get rid of that synovial fluid and maybe put a little steroid in there and quiet them down and perhaps take away the signs. Unfortunately, and Celia and I talked about this a little bit, a lot of times when you see this, it occurs so rapidly, the progressive signs, the horses will go from seemingly normal to almost falling down within days. And here's what a normal articular cartilage ought to look like. Here's what some of the ones that we see on these horses. And remember, some of these horses are less than 12 months of age when we see these kind of pathologies in there, and it's quite dramatic. And again, just showing these, what they can look like. They can go from very small lesions, like up on the top left, to very large ones, like on the bottom left. And then, again, if it affects both sides, here's what it does to the canal. So it takes away room for the spinal cord to live, leading to the problem. In the next group of talks after this one, I'll talk a little bit about both medical and surgical management of this. But this is pathology, again, another part of Dr. Jane's PhD. And so we started looking at this with micro-CT and measuring the frequency and the severity analysis of these lesions on there. And sometimes they were just superficial cartilaginous lesions. And interestingly, there was a recent paper, right, in the Equine Vet Journal showing a description of a surgeon that went in there and removed one of those articular OCD fragments off of an articular process. I've been bugging Dr. Bramlage and Dr. Ruggles to see if they would start putting their scope in there and doing some surgical correction that way, because perhaps if we could do it at an early time, it would be helpful. We'll just move through here. These are just to show how some of the lesions can be quite small. Others can be, again, quite large or deeper bone cysts. And then, here we have a fully grown or a bone cyst in there. So the same pathologies that occur in the long bones can be occurring here. I feel like I'm putting everyone to sleep. So this is just a summary of the kind of lesions that we saw in Dr. Jane's PhD, and these were all yearling thoroughbreds that I had done the neuroexam on. Either some of them had myelograms, others did not, but all of them had at least radiographs done, and all of them went to postmortem. After following postmortem, we brought them back and put them in the magnet, and we did that within hours of their death. And so I hope I don't offend anybody talking about research, but again, sometimes it's just an important thing for us to be able to get an answer. And this is, here's an OCD manifestus series, seeing the very dramatic changes all the way from what it looks like grossly, what it looks like on MRI, and what we might see at the histologic lesions. Again, and in here, with these deep lesions, there was, again, a replacement of what should have been normal bone with fibrous bone. So in this, we saw articular cartilage and bone lesions. They occur with increased frequency. And one of the interesting things is Jennifer's work, she just completed here not that long ago. And yet when we went back to another of our residents at Ohio State, Randy Stewart, had published some work probably 25 years ago showing similar things. So I think this problem has been the same since its origin, probably, I don't know, all the way back maybe to the 50s. But again, it's a developmental problem. So what's the role of genetics? This is the last part that we'll talk about in this first session, and it's an important thing. So there's one family of horse in central Kentucky that I've been following for a long time. And this particular mare she was a wobbler herself. She had 9 offspring. I think I examined 7 of them. We've done surgery on another of her fillies who's gone on to produce things. In between some of these wobblers, she's produced a horse that made $1.6 million, was quite nice. Then he became affected after he'd made $1.6 million. It showed. So I'm wondering, and when I looked back at the history on that horse and talked to the trainer, I noticed that for the last 3 months of his racing career, they were treating him for EPM. So I'm guessing that he was all along, nobody wanted to look at his neck. But at any rate, so we do have a few mares, and whilst I was still at Ohio State, one of the individuals, a man named Duncan Alexander, owned an insurance company called American Livestock. And so Duncan worked with us a lot to do this. And so we took another mare. We bred that mare to 6 different stallions. We got 5 offspring out of that, 3 colts and 2 fillies. Every one was a wobbler. So there are a few mares that have seemed to stamp their babies very, very hard. Otherwise, most mares that have a wobbler will have 1 off, and that's it. So majority of the mares, but I have been, looking really hard at some families, and hopefully when we get enough samples from horses in this family, we'll be able to understand the role of genetics. So what is it that makes, similar genetics turn into 2 different looking species? Well, so the way we did it was we did genome-wide association studies. So we took single nucleotides, polymorphisms, and did a SNP study on that. And just to sort of put it in simplistic terms, something as simple as chestnut coat color, it all lines up, at one spot. So, okay, this is an important site for where you're going to inherit genetic coat color. Here's what we got for the wobblers. So you can see on multiple chromosomes, there are certain loci that look like they may be important. Some of these are the same ones that are abnormal in the OCD of Hox in some of the warm bloods. So, it may be that the problem that's occurring in the appendicular skeleton is the same problem that's going on here in the neck. Am I at 5 minutes yet? Have I gone over? Okay, so I'm on my last couple slides. In any event, we do believe there's a role for genetics, but it's not simple. So we've identified multiple loci in these association studies. It's most likely a complex trait, multiple genes that are likely to be involved. It fits with what we know about these other factors, such as nutritional and problems in other parts of the body. And we are still doing a big genome-wide association study. And what's it analogous to in something like we might see in people with type 2 diabetes? There's a big interplay between not only the genetic role, but all these epigenetic factors, the role of diet, the role of exercise, the role of gender, the role of trauma. So there are other factors, and the good news is we can control many of these. So maybe even if you had a horse with a genetic predisposition, you could use that animal in some way if it had other characteristics that you liked. And we all know that the number one thing in the thoroughbred industry that's going to determine whether or not a horse is good enough to be a stallion is, can they run fast? Doesn't matter how they're put together. If they can run fast and win races, they're probably going to make it as a stallion. So what have we learned in 30 years? Well, we know that we've improved our ability to make diagnostic testing, but we still aren't to where we fully need to be. We know that it's a generalized bone pathology and that the cartilage lesions are important. Bone and cartilage pathology support the abnormal vertebral development, and that it's probably a complex genetic trait that is really, really key about that. So here we are. We were more casual at part of that day. I think we were down we actually met at Lloyd's for part of that meeting, didn't we? Was that where we were? You remember? Yeah. So, now, is Lawrence, I don't know, is he still practicing?